My name is Joachim Rigotti, and today we're going to talk about fibromyalgia with a particular emphasis on the clinical physiology. What actually happens within the body in an individual with fibromyalgia, and how does that lead into how we should deal with somebody. We won't touch too much on the management, that'll come in a separate video. So this one is all about the theory behind fibromyalgia. We're first going to begin with the overview. What actually is fibromyalgia? If you've never heard of fibromyalgia before, how would we describe it? And the first and the most vital symptom of fibromyalgia is the pain. So fibromyalgia is chronic, widespread pain. It is pain throughout the body. So each area of the body, the limbs and the trunk have a sensation of pain. That is the main symptom we have to think of when we think of fibromyalgia. However, it may also come with other additional symptoms. So whilst pain is the number one symptom, we may also get fatigue, sleep disturbances, and also other cognitive issues. So issues in thinking, issues in memory. And we tend to sometimes refer to those as a fibro fog. So it's mainly pain, but it does have those other symptoms, the fatigue, sleep, and memory issues. Now, in terms of how prevalent is fibromyalgia, it is actually not a rare condition. It affects around 2 to 5% of the general population, which doesn't sound like a lot, but actually when you compare it to other conditions, it is actually very similar to things such as chronic low back pain and depression, which tend to be some of the most common conditions around. So fibromyalgia is not a rare condition. The reason it's so contentious, why is there so many questions around fibromyalgia, are these next 2 points. The first one, there is no known single cause. So with a lot of diseases, we have a single cause. We have malaria, Lyme disease. We all know, there's a single cause. Same with deficiencies. You're deficient in this thing, and so we know the single cause. And therefore, there doesn't tend to be much debate around it if there's a single cause. However, with fibromyalgia, there isn't a single cause, or at least we haven't discovered one single thing which starts fibromyalgia. And so there's a lot of debate, a lot of theories, and so there's a lot of questions associated with it. And that really bleeds into the last point. There currently is no cure. When you look at a cure, oftentimes if you know exactly what triggers something, you can then target that particular thing, and if you do that successfully, then you have yourself a cure. However, with fibromyalgia, we don't know if there is a single cause. And so we can't really create a cure, because in order to do that, we would need to know exactly what causes it. So because there's no known cause and there's no cure, it has a lot of theories that build around fibromyalgia. And that really is a quick little overview. It's mainly pain, but there are other symptoms. It's actually quite prevalent, and there's no known single cause and no known cure. So now we're gonna move on to asking ourselves a few questions, really trying to get ourselves in the correct frame of mind to tackle fibromyalgia. So how should we be thinking of fibromyalgia? And the first place to start is thinking about pain. The main symptom of fibromyalgia is that pain, the pain everywhere throughout the body, so we should know a little bit about pain. And the question to ask, is pain a sensation or is it an experience? And the answer is that pain is an experience. It is not a sensation. And we'll quickly talk through why. The first point is that there is no single pain center within the brain. Oftentimes with the brain, we tend to view it as all the different areas all have their own individual responsibilities. That's to do with vision. That's to do with what we hear, what we think. We tend to group it. However, with pain, it is actually multiple brain areas activating simultaneously, and all those areas activating at the same time then give us the overall experience. And we really can separate it into 2 parts. The first part is the one we tend to think of, the actual physical sensation. So in our tissues, the muscles, the ligaments, tendons, and the joints, we may get some damage and some inflammation. That then gives a signal to the nerves, they fire off, and we get a signal through our nervous system to our brain. And in the brain, that is kept in a single area, and it just tells the brain we have a sensation, it is this intensity, it is this type of sensation. So it only tells it exactly what we feel. However, that is then coupled with all the areas in the front of the brain, and they are involved in the emotional and situational context of pain. So that is really what we could describe as the psychological elements. And it is the combination of the physical sensation and the psychological element combined, which then give us the pain experience. So whilst there is a sensation component of pain, the actual pain we then end up feeling is actually an experience, and it is because it is a combination of multiple brain areas at the same time. And an interesting point is the areas in the front of the brain, what we might term all the psychological areas, they are responsible for generating how unpleasant the pain experience is. So whilst the physical sensation may go up and down, actually how just horrible and disgusting that pain feels to us is all developed in the front of the brain and is not due to the amount of tissue damage in our skin. And when we look at how disabling pain is, the amount of suffering and unpleasantness we feel actually has a larger role to play than the pure physical sensations. And this has quite an important implication for current treatment of pain. When we look at treating pain, oftentimes we try and target the sensation component. We try and block the pain, and we presume if we block the pain, we get rid of the whole experience. But of course, we're only targeting half of the experience. And actually, we're targeting the half of the experience which isn't the most disabling component. We are still left with the unpleasantness and the suffering aspect, which tend to be more disabling. Which is why, if you look at current management for pain, there is an emphasis now on psychological therapies, because we need to manage both the physical sensations and those psychological elements in order to target both sides of the pain experience. Another factor to consider is that actually when we feel the experience of pain, an increase or decrease may be due to either side. We might well have an increase in tissue damage, that of course will increase our pain experience, but we might as well have an increase in emotional distress. If we're going through a lot of stress at the moment, that plays into one half of the pain experience, and so an increase in that one will also give us an increase in pain. So when we feel an increase in pain, it may be from either side of the pain experience. Yes, it may be increased damage, but it might also be an increase in emotional distress. And that is an important factor to remember when we think of pain flare-ups. So pain flare-ups are where we have a temporary increase in pain, and that temporary increase of pain, we tend to associate it with an increase in the worsening of our condition. I must be feeling more pain because there's more tissue damage. But it is not the case, because the pain experience has two components. So it may well be an increase in tissue damage, but it might equally be an increase in emotional distress. So those are very important to remember. Our next question is looking at the difference between a syndrome and a disease. So is fibromyalgia a single disease, or is it multiple conditions presenting the same? And the answer is that fibromyalgia is a syndrome, not a disease. And we'll quickly go through the difference now. The first part, a disease usually has a clear cause. You were bitten by a snake. You ate a bacteria in a food. There's something usually where it's very tangible. That was the cause. However, with a syndrome, rather than working from the start, and we always like a good story, where did it begin? However, with a syndrome, we actually begin at the end, with the presentation, with the symptoms. And therefore, a syndrome is a collection of symptoms without a clear cause. And if you think of things such as irritable bowel syndrome, chronic fatigue syndrome, fibromyalgia syndrome, just for those three examples, the way they are diagnosed is with the presentation. So you have perhaps two individuals and they are presenting the same. So they have, for example, the same three symptoms. In the case of fibromyalgia, perhaps they are both saying, I have pain in every area of my body, I have unrefreshing sleep, and I suffer from tension type headaches. Perhaps they have those three symptoms, so they both get the same diagnosis. They have the same syndrome, and it's all based on how they were presenting. And at that point in time, there has been no mention of what has caused it. And that is one key difference. With a disease, it's the perfect story. It starts with a cause and it goes forwards. But with a syndrome, it's the other way around. We first begin with the symptoms. Okay, something has happened, we're not looking at it yet, and you are now presenting with this. And we group individuals depending on how they are presenting. The next part is that with a disease, there's often a single cause. So you were bitten by that snake, you did get that bacterial infection. It often is just a single thing, and that leads into its management. Very easy to treat because it was a single thing, so long as you can actually target whatever that thing was. However, with a syndrome, because it's all about how a person presents, it may actually be multiple conditions simultaneously. It does not have to be that all those symptoms are caused by one single thing. So in our case of fibromyalgia, we had the pain, the fatigue, and the headache, for example. Those may well be three different conditions, each one giving their individual symptoms. It does not have to be from a single cause, which again is a different frame of mind to a disease, which has a single cause and is a single condition. A syndrome might actually have multiple conditions, which then give us the end presentation. This leads into the physiology with a disease. Because it's a single thing, it tends to be studied very nicely, and so we tend to know the biological pathway. On the other hand, a syndrome, because it might be from different causes and might actually be multiple conditions at the same time, they all have different pathways, they have different risk factors, so it's a bit muddied when it comes to researching exactly how things progress, because you're looking at different things in different people, so nothing tends to line up perfectly. So that's another big difference. And that then goes that diseases tend to be predictable. Okay, once you've been bitten by a snake, for example, you have multiple days, so we know what happens on day 1, day 2, day 3, for example. However, with a syndrome, because we don't know exactly what's caused it, we therefore don't know exactly what the physiology will be, it's very hard to stage it and to give an accurate prediction of what the outcomes will be. Okay, so our next question is the difference between an active condition and a residual. So is fibromyalgia an ongoing process, or is it a structural change? And the way I'm viewing this is that there may be different subtypes of fibromyalgia. Going back to it being a syndrome, people may present the same, but actually the two individuals, though they may present the same with the pain, the fatigue, or the headache, for example, they may have two very different conditions going on within their physiology. And we'll quickly go through the difference. So in an active condition, there is an ongoing pathological process. For example, perhaps it's an autoimmune condition. That autoimmune condition is still in that individual. And so it is continuing. It's an active condition. That person still has something within them which is continuing. However, perhaps in one individual, what has initiated the fibromyalgia may no longer still be there. So rather than being an ongoing process, perhaps they had an infection. That infection triggered a lot of adaptations to happen in their body. Now they've cleared that infection is long gone. However, the remnants of that infection, the sort of disaster that it has caused, is still there. So you may have two different types of people, those where they are presenting with fibromyalgia and the thing which caused it is still there, or you may have individuals with fibromyalgia where what caused it is no longer there, and what's driving their symptoms is all the changes which happened during that initial trigger stage. And that leads to these 2 points. So in the active condition, the thing that caused it is still there, and so the symptoms are continue to be driven by that ongoing process. Whilst in an individual, for example, from an infection, that infection has caused multiple adaptations to the pain pathway. Now that infection is gone, it is the pain pathway, its adaptations, which are maintaining the pain. So those are the two differences. Some individuals with fibromyalgia may have an active ongoing condition, whilst others, they may actually just be from the remnants of a previous triggering event. Okay, so now we'll move on to the pathophysiology. So what do we actually know? So we've talked about the theory behind it, setting our mindset to fibromyalgia. What do we actually know? So let's go through a quick overview of what we believe happens in fibromyalgia. The first thing is somebody has some risk factors. So they are predisposed to fibromyalgia. So for some particular reason, they have a predisposition to developing fibromyalgia. With that predisposition, they are then exposed to a triggering or initiating event. And that initiating event causes issues throughout the body, and those issues throughout the body cause signals to go through the pain pathway. So the initiating event, for some particular reason, is activating all the nerves throughout the body, perhaps not all of them, but a large majority of them, and that activation is causing them to be activated on a continuous basis. So there's a pain signal going through the pain pathway. And that continuous signal through the pain pathway causes it to adapt to pain. And it is those adaptations which then allow the pain to be maintained. So an individual, they have a predisposition, they then are exposed to a trigger. That trigger then causes the nerves to be activated for a long period of time. As they're activated for a long period of time, they then adapt and change almost into a pain setting. They become on overdrive, and it is that adaptation that then allows the pain to be maintained. So that is a quick overview of how fibromyalgia seems to develop. So what do we actually know? The risk factors. We have a rough idea. Nothing is ever perfect. They're always discovering new things, but we have a good rough understanding of what the risk factors are. And as a broad overview, it is any stress which is placed on the body, it will increase the risk of fibromyalgia. And we think about both physical and psychological stress. So let's quickly go through a few. So when we think about physical stress, we think of trauma, we think of infections. So perhaps there was a large injury, so perhaps there was a motor vehicle accident, they broke multiple bones, that would be a physical trauma, which might then give all those pain receptors a signal, and that's what triggers it. Same with an infection. Perhaps they had an initial infection, that went throughout the body, and that triggered it. Then having a rheumatological condition is also a risk factor for fibromyalgia. Autoimmune conditions such as rheumatoid arthritis or lupus, they have an increased activity of their immune system, and therefore any sort of thing they have, an infection, will be heightened. So they'll have an increase in the amount of immune cells which are working, and that might predispose them to fibromyalgia. So those are a few of the physical risk factors. Then we have psychological. So early life adversity, any childhood trauma is a risk factor, as is any psychiatric conditions, anxiety and depression. All of those will predispose us to developing fibromyalgia. And when we look at all the risk factors, what we see is that females are 1.5 to 2 times as likely to develop fibromyalgia compared to males. Now, why might this be? What it seems to be is that females are just more likely to have all those individual risk factors. They are more likely to have suffered early childhood trauma, more likely to have anxiety or depression. Now, when it comes to physical trauma, they may not be any more at risk of having a physical trauma. However, because females tend to have an increased activity of their immune system, any physical stress they have will be amplified just that little bit more due to their immune system being slightly more active. And that is why females tend to have a greater risk of developing fibromyalgia. That's the risk factors. Next, the initiating events. And this is really where fibromyalgia gets all its dialogue, all its debate. We don't really know the single cause of fibromyalgia. The initiating event is still a bit elusive. And why might this be? Well, fibromyalgia as a syndrome may have many causes and may even be multiple conditions simultaneously. So with research, they're always trying to look at what is the cause. However, if you have 100 people with fibromyalgia, they may all have different causes, and furthermore, within an individual, perhaps they have 2 or 3 conditions simultaneously. So trying to narrow it down to a single thing is probably not a realistic view of fibromyalgia. We have to think, what is that individual's initiating event? It may be different from the person next to him. Yes, they may present the same. That's how syndromes work. But what caused it may be different. And we'll quickly go through some of the theories as to what might be initiators. The first one, this is the most common theory, is all about an autoimmune condition. In particular, the theory is that there is an autoimmune condition which attacks the dorsal root ganglia of the nerve fibers. So the dorsal root ganglia is where all the cell bodies of the nerves are housed. So all the main structure of the nerves are housed in a little round ball right near the spinal cord. And the presumption is that there is some autoimmune condition which attacks that area. And it causes these small fibers carrying sensation to be damaged, and that then causes a pain signal to be generated. So that's one theory. That also goes through to something called Sjogren's disease. And it is an autoimmune condition, and actually it is known that individuals with it have a very similar autoimmune reaction to their nerves. So it may well be that some individuals who are diagnosed with fibromyalgia may well have a sort of a different presentation of Sjogren's, and so that's something to consider. The next part is chronic low-grade inflammation. That is where we have just a low grade, so a low amount of inflammation, but it's ongoing. So it's just a little bit more than we should have. It's not huge, but it's just a little bit more than we should have, and it's ongoing. And it tends to be throughout the body. And what will that do? Well, that little bit of inflammation will just be tickling the nerves of our body, sending just that little bit more signal than it should be, and that might initiate the fibromyalgia over time. Next part, infections or toxins. So perhaps we have an insult. Now those toxins may be from the environment, or they might be a medication. We don't really know. But either way, an infection or a toxin will go in the body. It can affect the whole body, cause perhaps some damage somewhere. That will then initiate the pain pathway. Next, mitochondrial issues. So the mitochondria are the little cells within our body which generate energy. If the mitochondria are damaged, perhaps from an infection again, the mitochondria, they are damaged, and so they don't produce as much energy as our tissues need. If our tissues are not provided with enough energy, they may begin to accumulate damage, and then that damage triggers our pain pathway, and so fibromyalgia begins. The next one, multiple musculoskeletal injuries. So this links back to the risk factors of having physical trauma. Perhaps having multiple injuries throughout our life slowly begins to accumulate the symptoms of fibromyalgia. We have a low back pain, then a shoulder injury, then a knee injury, and over time we have almost a stepwise fashion in developing chronic pain. We go from area to area, so it seems to present in a stepwise fashion. That could well be it. Or for some particular reason, perhaps it all happens at once. The next two are a bit more controversial, but interesting nonetheless. The first sort of interesting theory is an excess cerebral spinal fluid. So throughout our nervous system, so the brain and the spinal cord, they are coated in cerebral spinal fluid, which gives them nourishment. This cerebral spinal fluid has a pressure. However, if that pressure increases, it will compress ever so slightly the nerves. And if that happens, it may well be that that then causes damage to accumulate, that little bit of pressure. So that's one theory. The next would be maybe it's a degenerative condition. Perhaps individuals are born with fibromyalgia, and over time it just causes this degeneration throughout the body. And again, that might well lead to a stepwise presentation. First they might have pain in one area, then another, and it just slowly progresses. So that's another possible theory. And that concludes the possibilities of the initiating events. And that leads us to the last step, the end state. And we have a little bit more of an idea again compared to the initiating event, because if people are presenting with fibromyalgia, we can then look at their physiology and see, well, what seems to be off here. It doesn't tell us what caused it, but it does tell us what changes we see. And in general, we tend to see that fibromyalgia occurs due to multiple changes in the pain pathway. That is a consistent finding of individuals with fibromyalgia. They have multiple changes throughout their nervous system. And I'll quickly touch on different types of pain conditions here. And at the top, you can see nociceptive, neuropathic, nociplastic. And these are really three groups of pain conditions. And they're really all about where is the pain signal coming from? Where does that physical sensation that we have damage that goes to the brain, where does it originate from? Nociceptive tends to be the more classic version. We damage ourselves. So we slam our finger in the door accidentally, we've caused some damage. That damage and inflammation sends a pain signal, and that gives us a very localized pain. If you trap your finger in a door, it's going to hurt your finger. And we tend to manage that then with very localized therapies to try and improve the damage and improve the inflammation. The next part, neuropathic. This is again a localized damage, but rather than it being the tissues, we're not damaged the bones or the muscles. In neuropathic, we damage the single nerves themselves. So not the whole pain pathway, it's still localized, it's just we've damaged the nerves. We tend to think of diabetic neuropathy and also chemotherapy. So if we have a toxin which is toxic to the nerves, then that will also give us that neuropathic pain. And that tends to be also rather localized depending on what nerve is damaged, and we get the additional symptoms of nerve damage of numbness and tingling along with the pain. Now the final pain condition is where fibromyalgia sits. So it's not caused really by damage to the tissues, is not really caused by damage to the nerves. The thing which maintains fibromyalgia is changes to the nervous system, which is where you might hear it called a primary pain condition. The pain is not coming from something else. It is actually the pain pathway itself which is generating the pain. So we, for some reason, have those adaptations to pain. So the pain pathway has adapted, and now it itself is generating the pain. We don't need anything else to change the pain. And we'll quickly now go through what changes we tend to see in the pain pathway, which then give rise to that. Now, all pain pathways tend to begin with the receptor. Right at the end of the nerve, we have a receptor which is trying to look for, is there a pressure? Is there a sharp touch? Is there vibration? We have all those receptors. And what we tend to see is that within pain conditions, the receptors increase in sensitivity, which means that then touch, so if we just touch ourselves, where it previously wasn't painful, now it may be painful. And then even furthermore, painful sensations are now even more unbearable. That's the first thing that happens. The receptors at the end of the nerve become more sensitive. The nerves themselves can then also amplify the pain signal, so they get better at amplifying the pain signal, and they might even generate a pain signal themselves, called ectopic firing. So the nerves can amplify the pain signal. And then we get to the dorsal root ganglia. We mentioned them before. This is where the cell bodies of the nerve fibers are located. And within there, we can get something interesting called crosstalk. So all the individual fibers which are taking sensation from one particular area, they usually are just from that one particular area. However, if within the dorsal root ganglia, they sit really close to each other, they can talk to each other and set each other off. So now, rather than the pain being in one particular location, the pain will begin to spread as the nerves begin to talk to each other and set each other off. So that's the first stage, and that all happens in what we call the peripheral nervous system. That's all the nerves in our periphery. Imagine all the nerves within our limbs, for example. Then we move to the central nervous system. This includes the spinal cord all the way up to the brain. And when we look at the spinal cord, what we see is multiple changes. And really all these changes cause the pain signal to be amplified and to last longer than it usually would. So the pain gets amplified. The second thing that we should know is something called sprouting. Now what sprouting is it's a movement of some nerve fibers that take one sensation and they sprout into another area. In this particular case, it is nerves which take soft touch, so really light, gentle touch. That is actually a different nerve fiber from kind of the pinprick sensation we would get. So it's two different nerves. But what happens in chronic pain is the nerves taking gentle touch begin to sprout upwards in the spinal cord, and they begin to sprout into the pain areas. And what this causes is that then when we have a soft touch, we feel it as a pain signal, what is technically termed allodynia. So the receptors at the end of the nerve increase the pain signal, as do the nerves and the spinal cord. So that's boosting the pain signal. But now we have an additional thing where soft touch is now also felt as pain. From the spinal cord, the pain signal goes up, up, up to the brain stem, right at the bottom of the brain. And the reason the brainstem is important in pain is what's called the descending inhibitory pathway. From the brainstem, we have pathways that then go down. So most of the pain pathway tends to be upward bound from the tissues to the brain, but the brainstem is the other way around. It is actually sending pathways to the spinal cord, and it is releasing neurochemicals, in particular serotonin and norepinephrine. It releases these into the spinal cord, and it alters how the pain is felt. We're going to focus more on norepinephrine. When norepinephrine is released, it causes the pain to be dampened. So imagine it as a type of adrenaline. If you're in a rugby match or an American football and you get an injury, norepinephrine can be released and it will dampen the pain temporarily, which is a good thing. It's also how the placebo effect works. This release of norepinephrine dampens the pain. However, in the state of chronic pain, what appears to happen is the balance between the pain signals coming up and the dampening signals going down. Those usually balance out nicely. However, in chronic pain, for some reason, that balance shifts to now the pain signals being more than the dampening signals, and so the pain is no longer dampened. So that's the change that happens in the brainstem. The final part, you'll be glad to hear, is the brain. Now, we talked about pain as an experience, so we have the different areas in the brain. And the real adaptations which happen in the brain are all the ones which happen in the front of the brain, that medial pathway. And what appears to happen is the brain circuit, which deals with how much we suffer and how unpleasant pain is, become hyperactive. And so pain becomes more unpleasant because those brain areas become hyperactive. They're used more, so they become really well used. The brain gets really good at using those unpleasant pain pathways, and so it just develops. And that can lead to secondary symptoms of anxiety. So the same system, the same brain areas which are used to develop the unpleasantness of pain happen to also be the brain areas which are involved in developing anxiety. And so individuals with chronic pain may end up developing a secondary anxiety due to the overlapping brain circuits which happen to be dealing with pain. We're now going to move on to the clinical pathway. So what is the best practice for an individual with fibromyalgia? If they go and see a medical doctor, for example, what should the pathway be? How should they be treated? And the first step is the diagnosis. So diagnosing them. Are we dealing with a possible case of fibromyalgia? That's the first place to begin. And when we look at fibromyalgia, we have multiple questionnaires. So as a syndrome, it's all based off the symptoms. So we're not looking for a cause as such to have a diagnosis of fibromyalgia. We're all looking to what symptoms do they have and do they fit the brief? And the ongoing thought process that should be in the mind is, does this seem to be a pain condition which is occurring due to changes in the central nervous system? We're really trying to rule out any pain coming from tissue damage. We're always looking for pain because of those adaptations in the central nervous system. And the first place we start is something called the Widespread Pain Index. And it is an index of 19 areas across the body. And the individual with suspected fibromyalgia then ticks off what areas they feel pain within. And when we look at, do we feel pain there? A simple feeling of pain in that area is enough to have a tick in the box. Previously, in the 1990s version of the American Rheumatological Society's fibromyalgia diagnosis, there was a requirement for trigger points to be found. However, that's no longer the case. All we need is that it feels like there's pain in that area. If there is, we get a tick in the box. The second part of the fibromyalgia diagnosis revolves around something called the symptom severity score. And these are all the other symptoms which are not pain. So the widespread pain index is all about pain. Symptom severity score is all the other possibilities. And the first part is looking at fatigue, sleep, and memory issues. And that is graded, those three are independently graded from 0 to 3. 0 being no issue at all, and 3 being a severe problem. So is there fatigue? Is there sleep issues? Are there memory issues? 0 to 3. The second part is all about possible secondary conditions that may be present. We look at mood. So we're looking, is there a possible major depressive disorder here? We look at abdominal pain. Is there a possibility of irritable bowel syndrome? And we also look at headaches. May there be a migraine or a tension type headache going on? If yes, they get 1 point. If no, they get 0. And all those scores are then tallied up, and the maximum score is 31. If the individual gets 13 or more, then a diagnosis of fibromyalgia can be given. And you'll notice that this is a diagnosis of inclusion. If they meet the criteria, they may have a fibromyalgia diagnosis. It is no longer a diagnosis of exclusion as people may think. It is not where we rule out every single possibility, and only once we've exhausted that do we get a fibromyalgia diagnosis. Now it's a diagnosis of inclusion. If they meet the fibromyalgia diagnosis criteria, they may well be able to get a fibromyalgia diagnosis. One final point is something called fibromyalgia-ness. It's quite often seen in the anesthesiology world. And this is for individuals who score high on the fibromyalgia score, but do not quite get that 13 out of 31. If somebody perhaps has a 10 out of 31, they don't quite reach the diagnosis, but they are seemingly having either a very mild version of fibromyalgia or something similar. And it may be that some individuals who don't quite meet the fibromyalgia diagnosis may actually be better off being treated as if they do. I just wanted to also touch on what are termed fibromyalgia-associated pain amplification syndromes. Now, fibromyalgia, as we keep reiterating, is really caused by those adaptations to the central nervous system which amplify the pain. And there are also many conditions which have a very similar feature, where the amount of tissue damage we have does not match the amount of pain we feel. For some reason, in some conditions, it seems that the pain is being amplified by our central nervous system. And so these are all conditions which are in a similar way to fibromyalgia. They are being amplified. We have things such as temporomandibular disorders. Those are the disorders of the jaw. We have tension and migraine headaches. We have irritable bowel syndrome and the functional gastrointestinal disorders. We have interstitial cystitis, or irritable bladder, you may call it. We have dysmenorrhea and other pelvic pain syndromes. And the final one there is vulvodynia. All of those appear to have a similar underpinning to fibromyalgia, where yes, there may be some physical damage perhaps, but the difference between the physical damage and the pain levels are quite stark, and there appears to be an amplification of the pain. Now, step 2. Once we think we are indeed dealing with a diagnosis of fibromyalgia, the second step is, could this be something else? So are all the symptoms of this individual actually coming from an underlying pathology? We may think of rheumatological conditions. Perhaps it's neurological conditions. And the important part here is that with fibromyalgia, yes, it is the nervous system, but it is the sensory nervous system. It's all these small fibers. We should not have much issues with our strength. Now, perhaps we have issues with our strength because it hurts, but it shouldn't be a neurological level of weakness. If there appears to be any issues with the large fibers which control movement, that is perhaps looking at a different diagnosis other than fibromyalgia. We may have endocrine disorders, connective tissue disorders. There may be some medications which give us widespread pain, so we need to look out for those. And we need to think of ongoing infections. So all of those we need to be wary of, and if they are present, it might go against the diagnosis of fibromyalgia, because actually the pain is no longer coming from the nervous system, it is coming from one of these diagnoses. So we have to keep an eye out for that. And that bleeds into our tests. Now, when it comes to the test for fibromyalgia, really we are just trying to make sure that there isn't any really big general health issues that we're missing. So there aren't any specific tests for fibromyalgia. There isn't the fibromyalgia test. Really, we're trying to just rule out other conditions with the test, making sure there isn't any underlying health issues, which we first need to try and mend before going ahead with fibromyalgia management. And perhaps if there are any rheumatological conditions, we have to test for those as well. So the tests which are routinely done are a complete blood count and a metabolic panel. They are a thyroid stimulating hormone test, and any test for an anemia or a low vitamin D, and anything looking at inflammation, so the sedimentation rate and the C-reactive protein. One little bit there again is that if there are signs of an inflammatory arthritis, then you can get an anti-nuclear antibody test or a rheumatoid factor test. However, if there are no signs of inflammatory arthritis, then those tests aren't warranted due to the risk of a false positive. And the final one would be a sleep study. It may perhaps be warranted. Now, once we think we have done the possible inclusion criteria for fibromyalgia, we've gone through the differential diagnosis, we've done the tests, we can then think of categorizing the individual. And we can have a few different categories. The first, as you'd imagine, would be fibromyalgia. They meet the criteria, there is no other complications or other diagnosis, so they are just fibromyalgia diagnosis. The second possibility is kind of a mixed presentation. So if they meet the criteria for fibromyalgia, so they seem to have fibromyalgia, however, they also have another condition ongoing, but that particular condition doesn't explain all their symptoms, they can have a comorbid fibromyalgia. So perhaps they have rheumatoid arthritis, but that rheumatoid does not explain all the symptoms they have, therefore they would have a fibromyalgia and rheumatoid arthritis. They would have a comorbid fibromyalgia. So just because you have another condition doesn't mean you can't also have fibromyalgia. Because again, the thought is fibromyalgia is all about pain being amplified from the central nervous system. If that seems to be a particular component of the condition, then it can be a comorbid fibromyalgia. And the third part is, as you'd imagine, not fibromyalgia. So they don't meet the criteria, and or there is another diagnosis which explains all the symptoms, then it's not fibromyalgia. Step 5, seeing a specialist. Now, fibromyalgia, there isn't currently a specialist for fibromyalgia. Most of the work of fibromyalgia seems to nowadays be done in rheumatological world. So perhaps if they are to go to a specialist, the rheumatologist seems to be the best place to go. But really, we only go there if there is a suspected concurrent condition or an underlying severe pathology. So if they do meet one of those differential diagnoses, then they need to go and see a specialist. The other one is if initial management fails, then again they need to go and see a specialist. So those are really the two types. And the final thing we'll just touch on, this isn't a presentation on the management, but just to finish it off nicely, the first part of management is all about advice, all about understanding fibromyalgia, understanding that pain may fluctuate up and down, and that it is an ongoing condition. We don't have a cure yet, so we have to be willing that this will be an ongoing management process. And we also need to make sure that people understand that actually the quality of life we have does not always mean that we have to only manage the pain. We can have improvements in quality of life without directly targeting pain. So it's really that advice, getting a bit of hope that actually, although there is no cure, there are plenty of things we can do to improve quality of life. From there, we have things such as supervised group exercises. We have acceptance, commitment-based therapy and cognitive behavioral therapies. So those are the psychological treatments. There may be other things such as acupuncture or maybe a massage therapy. And the final one, these are in the NICE guidelines, are antidepressants. And the way those would work is by targeting the brainstem, improving that descending inhibition system, hopefully helping to dampen the pain. And that leads us to the conclusion. So what did we learn in this particular presentation? The first part is all about pain. Pain is an experience, not a sensation. It has two components, the physical sensation and the psychological components, and those both combined create the pain experience. And an increase in either one of those will give us more pain. So we have to think that pain is an experience, not a sensation. We also need to remember fibromyalgia is a syndrome, not a disease. When somebody has fibromyalgia, it is all because they are presenting with the presentation of fibromyalgia. It does not tell us what has caused it, or indeed if it is a single cause. That individual may have multiple causes, and compared to another individual with fibromyalgia, they may actually have a completely different cause. So fibromyalgia is a syndrome, not a disease. It doesn't have a single cause and a single pathway. There are multiple possibilities. The third point, we seem to think fibromyalgia, the continuation of it, really occurs from the changes to the central nervous system. So it's not inherently a tissue damage condition, it's all because the pain pathway has adapted to pain, and now it is either amplifying pain or actually generating pain itself. So the pain appears to come from the pain pathway itself rather than tissue damage. Like we talked about just previously, there may be multiple triggers and multiple conditions simultaneously. It is a diagnosis of inclusion, so it's no longer a diagnosis of exclusion. If they meet the criteria and there are no other differential diagnoses which completely explain the condition, then fibromyalgia can be given. And the final little point is that it is a multidisciplinary management. So when we look at managing it, we need multiple disciplinaries. Thank you for watching this little presentation on the clinical physiology of fibromyalgia. If you liked it, then please do like the video and share it with others you feel may benefit from it. Keep an eye out for the next video on the management of fibromyalgia, so please subscribe to make sure you don't miss it.